My name is Matthew Posen, and thank you for listening to my case poster presentation of Feeling Blue and Bleeding 2, Chronic Gastrointestinal Bleed and Blue Rubber Bleb Nevus Syndrome. Blue rubber bleb Nevus syndrome is a rare congenital condition characterized by venous malformations resembling blue raised lesions for which the condition is named. These venous malformations are primarily cutaneous or gastrointestinal, but can affect other organs including the heart, eyes, and central nervous system. Due to the cutaneous manifestations, this diagnosis is typically made in childhood, with adults instead presenting with iron deficiency anemia due to chronic bleeding. Below, we present a typical case presentation. A 20-year-old male with pathognomonic history of blue rubber bleb Nevus syndrome, as well as iron deficiency anemia, presented to the hospital with severe anemia of hemoglobin 3.3 grams per deciliter found on outpatient labs. The patient initially presented to his outpatient PCP with 6 weeks of progressive fatigue, pallor, lightheadedness, as well as bright red blood per rectum without melena or oral bleeding. Notably, the patient initially underwent as an infant surgeries for his blue rubber bleb Nevus syndrome for venous malformations of the tongue and throat. Physical exam on presentation to the hospital was remarkable for hemocoel-positive stool and venous malformations of the tongue, groin, and feet. Repeat blood work confirmed hemoglobin of 3.3 grams per deciliter, and the patient received 3 units of packed red blood cells with improvement of hemoglobin to 7.2 grams per deciliter. Other lab results included mean corpuscular volume of 64.7 femtoliters, iron of 10 micrograms per deciliter, percent iron saturation of 2%, and total iron binding capacity of 401 micrograms per deciliter, consistent with iron deficiency anemia. Therefore, the patient was started on intravenous iron sucrose. Esophagogastroduodenoscopy revealed venous malformation of the tongue. Colonoscopy revealed 3 non-blooding venous malformations in the ascending, transverse, and sigmoid colon, as seen in the middle of the poster, with the ascending, transverse, and descending colon venous malformations. As these venous malformations were non-bleeding, no acute intervention was performed. The patient's hemoglobin remained stable following the transfusion, and he was discharged home on oral iron supplementation and proton pump inhibitors with plan for follow-up with genetic specialists for blue rubber bleb Nevus syndrome. While prognosis of blue rubber bleb Nevus syndrome is good, with patients commonly having normal lifespan, a large concern for these patients is development of severe gastrointestinal hemorrhage or intussusception. Approximately 30% of the cases are diagnosed right at birth. However, a further 10% of these cases are estimated to be diagnosed at adolescence or later if a cutaneous malformation is not seen. With patients that do not initially present with the cutaneous malformations, diagnosis can be delayed until iron deficiency anemia is found on outpatient labs or severe gastrointestinal bleeding arises. Some patients present with intussusception, as the venous malformations can present as the nidus for the telescoping of the bowel. Blue rubber bleb Nevus syndrome treatment is typically tailored to a patient presentation, with most presentations requiring symptomatic management for the bleeding. As with typical venous malformations, patients with significant bleeding are treated with sclerotherapy or gland ligation. Serious or refractory cases may require partial gastrointestinal resection. Pharmacologic agents have shown mixed response with some promise in treatment with sirolimus for prevention of the angiogenesis and new venous malformations to decrease blood transfusion frequency.